Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to Part 3 of Cases from the Community, as tonight our clinical investigator panel will discuss the optimal role of endocrine-based strategies in the management of ER-positive breast cancer. We've been here the last two nights, and Wednesday we were talking about ADCs and ER-positive triple-negative breast cancer. Last night, HER2-positive breast cancer. Really looking forward to tonight. A lot happened at this meeting, obviously related to this question. Of course, our primary target audience in general is the community-based medical oncologists. We just got back from the ASH meeting. I was telling the faculty there, we did a program on AML. You think there's a challenge here figuring out what four SERDs. They have four menin inhibitors in AML, and they work by differentiation and they can cause lethal differentiation syndrome. So these docs are trying to keep up with a lot of the new findings in clinical research, and we're going to try to focus on things that will be helpful to them in their practice. We have a great faculty tonight, starting at the far side of the room, Dr. Angela DeMichele, Dr. Komal Jhaveri, Hope Rugo, Dr. Erica Mayer, and Dr. Seth Wander. So as always, we will be discussing the use of unapproved agents and regimens. So please consult the package inserts for more information related to the products we're discussing here today. So we're going to get started on this program, and as we've been doing the last three nights, we do have community-based medical oncologists who will be presenting cases here tonight and posing questions to the faculty. So we really appreciate what they do in working with us. Here's where we're heading. We have 5 modules, and each one we'll have a presentation, and then we'll do some case discussions. But before we get started, I loved Lisa Carey's discussion of the lidERA trial the other day, as she was talking about the history of endocrine therapy. So I just want to throw in my 2 cents in terms of my perspective on the history of endocrine therapy and show you something I don't think we showed very much before. I think one of the most important presentations in the history of oncology, and certainly in breast cancer. For us, this is when we got started after this. This was the 1985 NCI Consensus Conference on Early Breast Cancer. And there, Sir Richard Peto, the statistician, presented the first world overview demonstrating that adjuvant tamoxifen chemotherapy actually worked. And I thought you'd be interested to hear what he had to say. This is from a VHS tape for the people half the audience never even heard of a VHS tape. But here's Richard Peto.
If you're looking only for big things, then the only things that will contribute towards your aim are exaggerated claims, over-optimistic claims by people who actually are not being realistic about what they can achieve. Every year in the US, there are 400,000 cancer deaths, roughly. Of these, about 40,000 involve breast cancer. Now, realistically, the kinds of change that you're going to hear described, the kinds of trials that you're going to hear described, might, if we're lucky, involve avoidance, let's say, of 4,000 of those 40,000 deaths. Now, avoidance of 4,000 deaths is humanly worthwhile. I mean, there's nowhere near 4,000 people in this auditorium, and avoidance of the instant deaths of all of us would certainly be worthwhile. But it's a small percentage, and it's very difficult to pick out those kinds of small percentage. And so you've really got to get very accurate, very sensitive, large randomized trials.
So I actually went to the next, every 5 years he would have investigators come to Oxford and present the data. Amazing. He actually used transparencies. I don't know if you know what they are, these before slides. He'd use these transparencies. And he also would poll the investigators ahead of time and show that what they thought it was going to show, they didn't show, particularly the fact that the curve separated. Anyhow, that, and the other thing I just want to mention, too, is that 16 years later, in this room, was really the evidence of that. One of the largest trials, at that time, the largest trial ever done in oncology, may be prompted by this thinking, the ATAC study, actually presented by Michael Baum here, because San Antonio, for those of you who don't know, used to be in here in this hotel for, I think, the first 25 years. So anyhow, that's my perspective on the history of adjuvant endocrine therapy, and obviously we're going to be concluding this year's meeting, and very high up in that, Just to let you know, we're going to be talking about Ladera at the last module. I'm going to ask each faculty member how they would like to use, theoretically, giredestrant in their practice, both people to starting adjuvant therapy and on adjuvant therapy. So I'm really looking forward to hear what they say. But we're going to start out talking about localized ER-positive breast cancer, and Angie is going to review the issue of genomic assays, and then we'll take a look at a couple cases. Angie?
Great, thank you so much. I will say I gave my very first talk in this room 27 years ago, so it feels like it's come full circle. So I'm going to go quickly through the genomic assays that we have and the data we have for those. I guess I'm doing this, right? And so here are the things I'm going to cover. So in a nutshell, here are the genomic assays that we have, and they differ in terms of the number of genes, the constitution of those different genes, and essentially what they give us in terms of a readout. But essentially, at the end of the day, each of these is designed to differentiate high-risk patients from low-risk patients. And they have been validated in different ways. So the first 4 have all been validated for early risk, right, in the first 5 years. And it's very limited in those first 4 what we know about late risk. It's really the BCI that has been most validated for late recurrence risk beyond 5 years. There's high correlation between these different assays, as I said, that there's a common set of genes, and primarily these are the different groups of genes that are within these different gene expression profiles. But one major issue that differentiates Oncotype DX, the recurrence score, from the others is that it's more strongly driven by the estrogen module, while the others are more strongly driven by the proliferation features. So let's talk about the data for early risk in the first 5 years. And you have all of the slides, so I am not going to go into any detail about the ASCO guidelines, but I think it's helpful to have those because at a glance, it's easy to think about in whom I need to order these tests. So first, the Oncotype DX recurrence score. We're all familiar with the design of the TAILOR-X trial. And in the intermediate risk group, the group that was randomized between chemotherapy and no chemotherapy, the most recent update we have is from 2022, and you can see that there still is no overall benefit to chemotherapy for any of those endpoints that are listed there. Now, there is some data to tell us about the role of chemotherapy in these patients who have particularly high oncotypes over 25. The data that you see on the left is actually data that was calculated to get an idea of how much benefit to chemotherapy there might be in those patients who have a recurrence score of 26 to 30 or 31 to 100. Suffice to say, these are data that were generated. They're estimates. They're not based on any data because in the trial, everybody got chemotherapy. But on the far right, we do see data that came from the trial that looked at the differential effect of anthracycline in patients who had a recurrence risk of greater than 31. And particularly for those patients, we do see that there is a benefit, a small benefit to anthracycline. So there is a positive interaction that for those patients over 31, there's a benefit to anthracycline. For those below 31, there does not seem to be a benefit to anthracycline. And then we move to the patients who have 1 to 3 positive lymph nodes. And again, I remind you of the RxPONDER trial design. I think what's really important here is to recognize that there were very few T3 patients. There were very few tumors. There were very few high-grade tumors. These were on the lower risk side, even though these patients had 1 to 3 positive lymph nodes. And what you can see on the far right, and it's a little hard for me to see it from where I'm sitting, but that there, as we all know, was a differential effect for those patients who had a recurrence score 0 to 25, a benefit to chemotherapy for the premenopausal women, no benefit to chemotherapy for the postmenopausal women. And in the table that you see down below that comes from the New England Journal article, that this benefit is not the same for every score, that it differs as the score rises, the benefit rises. Now, if we move forward here, this is important because we know that it isn't just the score that dictates the risk. The risk is modified by these clinical pathologic features. And so RS-CLIN was designed to be able to help us factor in those clinical pathologic features in both node-negative and node-positive patients, so that when we're in clinic, you can go in and use this, and I use this tool all the time, to help me really get as close to an accurate, personalized risk assessment as I can. So if I factor in the patient's clinical risk to their score, you can see how different it is for low clinical risk versus high clinical risk for the same score group in node negative, and it's similar in node positive. Now we move to MammaPrint and MindAct, which essentially was designed to ask a slightly different question, which is, if patients are clinically high risk, could this gene expression profile identify a group that was genomically low risk who could still avoid chemotherapy? And the boundary that was used was to say that these patients had to have at least a 92% 5-year DMFS. It was a positive trial. The chemo benefit did increase over time, but overall we could see that patients who got endocrine therapy alone did not have any decrease in their benefit compared to the patients who got chemotherapy. Now, just as we saw a differential effect of chemotherapy with the oncotype recurrence score by age and menopausal status, we also see that here for MammaPrint. So age always modifies the risk assessment and the benefit of chemotherapy that we see, with greater benefits to chemotherapy in younger women, women under 50, premenopausal women, than for women who are older. Moving now to Prosigna, EndoPredict, and the Breast Cancer Index. The key here is that these are not designed to help us decide whether or not to give chemotherapy. They simply give us a risk estimate. And the key data that we have for these three signatures comes from a comparison that was done in the trans-ATAC group. Then you can see there that all of them actually differentiated high and low risk patients, the BCI, ROR, and EP-CLIN, all differentiating those patients actually better than the Oncotype DX and the MammaPrint. But this is really just risk. It doesn't tell us whether or not they benefit from chemotherapy. We also now have the blueprint that's available to us. This is also from Agendia. It's an 80-gene RNA-based molecular subtyping assay that basically gives us sort of a functional intrinsic subtype to tell us whether patients are luminal, HER2 type, or basal. I use this in very specific situations. For example, a patient who has estrogen receptor between 1 and 10%. I'm trying to decide if I'm going to give them endocrine therapy. I'd like to know if they have a luminal subtype or a basal subtype. And so that's, I think, a good application of this. And so I've given you the ASCO guidelines for each of these that are the most recent guidelines that you can use for your reference. And then let's just finish up with the Breast Cancer Index. This is important because 50% of the risk, or half of the risk that patients have, happens after 5 years. So we have front-loaded risk, half of that risk in the first 5 years, the remainder of the risk playing out beyond 5 years. And that risk is constant over time. So these patients never get to a point where they have no risk of recurrence. And that risk is dependent on their tumor grade and their tumor size. But this risk is real. We have numerous studies of extended adjuvant therapy, endocrine therapy for these patients. And I think for the most part, what you see is the benefit here is somewhere between 2 and 4%. So it's very hard to decide whether or not we want to ask a patient to take 5 more years of endocrine therapy, particularly if they're having a lot of side effects for such a small benefit. It would be nice to have a tool that could help us to determine whether or not they're really going to benefit from that. And that's what BCI is designed to do. It's got 2 components, a prognostic component to try to give us a sense of what that patient's risk is beyond 5 years, and then a predictive component to tell us whether or not they're going to benefit from additional adjuvant endocrine therapy. So 2 different pieces of information. The graphic that you see on the right, the distribution of the BCI scores, is simply to say that most patients end up in the low risk, low likelihood of benefit group. So when you talk to a patient about doing this test, essentially what you're going to be able to tell them is you've got about a 50% chance that you don't need extended adjuvant therapy. But in the off chance that you're in the small group of patients who would really benefit, this can help guide us. And this is just to show all of the different endocrine therapy trials in which this was validated, differentiating the high-risk group from the low-risk group. So I think this is quite well validated in terms of being accurate and helping us to determine whether a patient will benefit from extended adjuvant therapy. And again, here are the ASCO guidelines for your reference, and then a final summary. So I think that's it.
Thanks so much, Angie. So we're going to go to our first case, and Komal, I'd like you to give me your thoughts about this patient. Is a 47-year-old premenopausal woman of Dr. Matt Amaral, has an ER-positive, HER2-negative, node-negative tumor, has partial mastectomy radiation therapy, then gets entered on the prospective observational FLEX study and gets a mammoprint assay, which shows she's low risk. Here's Dr. Amaral with what happened and her questions.
She ended up being node negative. She opted to undergo mammoprint testing. She was found to have low risk of disease. Because her mammoprint was low risk, she did not require any chemotherapy. She was given the option of doing an AI as well as ovarian suppression, and she opted for the tamoxifen. She's currently approximately about 3 years out from her surgery and a little under 3 years out from being on the medication. I actually just saw her in the office a few weeks ago, and she kind of told me, oh, hey, by the way, I stopped taking my tamoxifen a couple months ago. I'm not tolerating it.
Wow.
I said, well, you didn't call me, so what's wrong? Her biggest complaints were the weight gain and the muscle and joint aches. And so I think from an investigator standpoint, are they seeing this a lot in their patients as well? Or is this something that they're not quite seeing as much to help with continuation of therapy?
Do you have any questions about the use of either mammoprint or Oncotype?
I think from an investigator standpoint, my question related to that would be to see if they prefer one or the other and why. We use both at my institution, and so sometimes it ends up being dealer's choice.
So, Komal, it would be interesting if we see SERDs entering the adjuvant setting, how it's going to affect adherence. But what has been your experience, I guess mainly with patients from New York in terms of adherence, just in general, AIs, tamoxifen in the adjuvant setting? What kind of assay do you use? You use both or either one? Also, a question I have, do you ever use any of these assays in the neoadjuvant setting? So here are the questions.
Yeah, no, I think great questions. For a premenopausal woman with low risk, so talking about genomic assays and my preference, I've been leaning more towards Oncotype and using that, given the more robust data that we have, including for prediction of benefit and not just a prognostication for the tumor as well. And it's just that we have a lot more data with the Oncotype. I think from an assay perspective, mammoprint is a great assay as well. But I think with the data that we have been utilizing Oncotype at our institution for all our patients. And so for a node-negative premenopausal woman with a low risk of some genomic assay that was utilized, I'd be very happy offering them endocrine therapy alone, and tamoxifen alone is very, very reasonable. But turns out after 3 years of being on tamoxifen, she's having a hard time with tamoxifen. Your question about, how often do we see adherence to be an issue? How often is toxicity an issue? I think it depends on also the risk and our recommendation of endocrine therapy for a higher risk patient where we are trying to do chemotherapy and or ovarian function suppression. With an aromatase inhibitor, the toxicity profile and the adherence could look very different in a young premenopausal woman compared to tamoxifen alone, which could be relatively a little bit better in terms of tolerance for the patient. So I think ovarian function suppression certainly can add on an extra layer of toxicity there. So for this patient, I think, you asked me about the lidERA data as well, which was great data yesterday. I'm very excited to see, after 25 years, having a new endocrine option being discussed with good data. We'll discuss a lot more in the last module, as you said, about that. But currently, the data set that we have there, the discontinuation rates were a little lower in the giredestrant arm compared to the standard of care arm. There was a lot of ovarian function suppression used in the control arm, 40% roughly premenopausal women majority getting ovarian function suppression, very few tamoxifen alone, 16% only patients. So I think the arthralgia rates look the same. So I'm not sure that we know that definitively, but in the metastatic setting, we saw that SERDs are much more tolerable.
So, Hope, before you comment, I just want to let you know that last night, one of your colleagues, Dr. O'Shaughnessy, was one of our faculty, and I said, hey, we're talking about genomic assays tomorrow night. I see you have a poster here from the FLEX study that we were just talking about that this patient actually went on. Can you sit down with me for a minute or two and talk a little bit about this FLEX study? And the next thing I knew, it was an hour later. My entire team was sitting there with their mouth wide open. Joyce was just, it was amazing. I guess there are going to be 20,000. There are 20,000 people in it now. There are going to be 30,000. Here, it looks like they showed that maybe you can pick out patients who might benefit, as we were just talking about with Oncotype, from anthracyclines. Any thoughts about this effort, the FLEX effort and MammaPrint, and how do you decide what kind of genomic assay to use? Again, you see more data coming out of this FLEX registry, and Joyce is super excited about what's going to be happening moving forward.
Yeah, I think, because we have the I-SPY neoadjuvant program shared among several here, we do MammaPrint in the neoadjuvant setting, so I've gotten really used to using MammaPrint and Blueprint as a way to try and optimize therapy. And it makes sense to me that if you have HIE2 and luminal B disease, that anthracyclines would show a benefit because these are very chemotherapy-sensitive tumors. It's possible that if we gave a better non-anthracycline regimen that you wouldn't need the anthracycline, but we haven't explored that. For the patients who have, in the neoadjuvant setting where we're trying to decide about chemo, these young women now where, if they have a single positive node, they're supposed to get chemotherapy. I find it's very helpful because Laura Esperin published now some years ago the ultra-low cohort. Right. And in that group of patients, even including premenopausal women, the outcome was excellent without endocrine therapy. Now, I don't think any of us are brave enough to just say no endocrine therapy, but it depends on the size of the tumor, and I don't think we know the size here, just that it's node negative. I think that even if you have a very low score, if you have a lot of cancer, your risks are higher than if you have less cancer. So size does make some of a difference here, particularly in a premenopausal woman. So that's how I use the test. Now, in the adjuvant setting, I always use Oncotype because I'm used to using Oncotype in the adjuvant setting. So, if somebody has a small cancer, I get an Oncotype. The rest of the people we're evaluating in the neoadjuvant setting, and we use ovarian function suppression in an AI in the neoadjuvant setting, a la the West German study group, where you can see that complete cell cycle suppression at the time of surgery correlates with very good outcome without chemo.
Yeah, we had Nadia Harbeck here last night. So, Erica, 2 cases of Oncotype. One, a 44-year-old premenopausal patient of Dr. Vishwanathan, who has a T2N0 ER-positive HER2 negative tumor with a current score of 19. And Dr. Astrow is a 64-year-old woman, locally advanced 19-centimeter ER-positive HER2 low mucinous carcinoma who does not want chemotherapy, Oncotype recurrent score of 18. Here are the docs.
Question here is, how are the experts deciding between chemotherapy and ovarian suppression? Are they routinely offering both, or would they choose one over the other? I would love to know what their opinion on that is, because I don't know if sometimes we overtreat these patients. But in her case, I did discuss chemotherapy followed by oophorectomy for ovarian suppression, and she's agreeing to do both. The other question that I often have is, I feel I've heard recent data about the breast cancer index, that being used to determine duration of endocrine therapy. That discussion does come up all the time. I think we do underestimate the side effects from endocrine therapy. It's not chemo, but it still takes a toll on women. The fatigue, the arthralgias, the mood swings, the low libido, things like that. It's a real quality of life issue, which I feel we underestimate. And it's easy for us to say, take 7-8 years of this pill. And especially when I'm doing ovarian suppression in younger women, they feel it. The hot flashes, the fatigue is not easy.
Any questions about your 64-year-old woman who didn't want to receive chemo?
She had a terrible breast cancer. She had a 19-centimeter tumor, stage 3B. She didn't want chemo. Oncotype was 18. One question for the faculty panel is, how meaningful is a low Oncotype in someone who's got locally advanced cancer or 3B cancer like this? But she didn't want it. I started on anastrozole. Then I added Abema. She had severe diarrhea. I just reduced it to 100 milligrams BID. And 100 BID, she really didn't have trouble with it. And she finished a 2-year course, and she's NED.
So, Erica, any thoughts?
So I think it's challenging to, I'm just going to talk about case one, to consider how to use Oncotype in our premenopausal patients in a way that helps us move beyond just giving chemotherapy to people. At my institution, I will say that we tend to err on leaning away from chemotherapy for patients who certainly have low Oncotype at premenopausal patients, as well as those in the intermediate range. And it's really not until we start creeping towards 25 when we're really talking with patients about Oncotype. I think part of this is that when you look at TAILOR-X and Responder, there really is not good capturing of use of ovarian function suppression or induction of chemotherapy-induced amenorrhea with the use of chemotherapy in those trials. And we know from the long-term follow-up of the SOFT and TEXT trials, at now 15-year follow-up, that there are substantial benefits in terms of prevention of disease recurrence as well as overall survival benefits. So we know that ovarian function suppression is a very powerful strategy, and perhaps we might even see equivalent benefits when we use ovarian function suppression as we've seen in those trials with the use of chemotherapy. So it's something that I might discuss with a patient and we make a shared decision together, but I'm not automatically giving chemotherapy to my kind of mid-range Oncotype patients. I will say, though, there is an ongoing trial through the intergroup called OFFSET, which is for patients premenopausal with node-positive disease or higher risk node-negative and an Oncotype less than 25 that randomizes patients to OSAI or chemo-OSAI plus minus CDK4/6 in either arm. We, as a breast cancer community, need to support that trial because we need to prospectively understand what is the role of chemotherapy in premenopausal patients, as it wasn't really adequately addressed in the prior trials.
So, Seth, any comments in terms of, patient doesn't want chemotherapy and you get a genomic assay to try to maybe encourage them, and also this question of genomic assays to determine beyond 5 years?
Well, as Erica trained me, we never disagree on a case like this. So I would echo and agree with all of that, particularly for these 16 to 20. I'm not particularly enthusiastic about chemotherapy. I think certainly 21 to 25 in that situation is worth a discussion, but even then, I think the data is somewhat underwhelming, particularly the point that Erica just made about perhaps suboptimal use of ovarian suppression and maybe extended duration anti-estrogen therapy impacting the magnitude of benefit. Certainly, we deploy Oncotype routinely in premenopausal and postmenopausal patients with tumors less than 5 centimeters and in postmenopausal patients with a limited amount of nodal disease. I think to the point we were just discussing, we get a little bit stuck with premenopausal node-positive patients because we don't have great data yet to de-escalate, even though in our gut and in our heart we feel like the biology of those tumors is not dramatically different with the lower Oncotype, particularly in the area of optimal treatment with adjuvant CDK blockade. I think the last case that we didn't explicitly talk about there, this is a really challenging case when the tumors are that big. In the TAILOR-X trial, that patient would not have been eligible, far in excess of the upper bound. And so at the same time, again, biologically, these lower grade mucinous tumors, they probably don't benefit as much from chemotherapy, but I would feel an obligation to mention the fact that that patient is not eligible, that the size of the tumor is particularly high, and that I would offer chemotherapy. And so I think there are certainly edge cases around here. And to the question you asked, we are absolutely using Oncotype to help risk stratify these patients and help encourage them if they need chemotherapy. I don't like to get in that situation. If I have a node-positive premenopausal patient who I really think needs chemotherapy, I'm not routinely doing Oncotype. If the patient is highly resistant to it and I'm sort of backed into a corner, I might think about doing Oncotype, again, to either convince her that she needs it or to make myself feel better if she declines it if the score is low. And we're certainly trying to optimize all forms of adjuvant endocrine therapy in those situations.
Angie, you had a comment, and also you were talking about extended endocrine therapy. And the NSABP B43 tried to attempt to look at that and didn't really show a benefit. But there are some data looking at mammoprint suggesting maybe that could be utilized. You talked about breast cancer index. What do you do in your own practice in terms of going beyond 5 years, Angie?
Well, First of all, I did want to just comment on the therapy for that postmenopausal patient. I think we've recognized that we do have a knowledge gap for patients who are postmenopausal, who have larger tumors, T3 tumors, N2 tumors. Do we believe that the genomic risk really should trump the anatomic risk? And to address that, because we felt that there was equipoise, there will be a clinical trial starting called Refine Low for patients who have an oncotype less than 25, T3 or N2 disease, randomizing patients to either standard endocrine therapy and a CDK4/6 inhibitor, or that plus chemotherapy, so we can definitively answer this question.
So, Komal, the patient wouldn't have chemotherapy, but she was agreeable to trying a CDK inhibitor, and that's your next topic.
Absolutely. Thank you so much for a great segue into CDK4/6 inhibitors, who and why. So I thought, before I delved into the details of the Monarchy and the NATALEE trial that led to the approvals of our CDK4/6 inhibitors in the early stage setting, I wanted to set the stage for the kind of patients that were eligible within those trials by talking about these 3 real-world data studies. So this is the first one when we think about who do we want to intensify early stage therapy for. So disease recurrence occurs within 5 years on standard endocrine therapy in 30% of our patients with node-positive, hormone receptor-positive, HER2-negative breast cancer. And this real-world data comes from the Flatiron database that we have, just reflecting upon the pattern in patients with clinical and pathological features resembling those that were studied in cohort 1 of the Monarchy trial. And we'll go a little bit more into the details of the Monarchy trials shortly. But cohort 1 was your node-positive patient population, 4 or more nodes, or, N1 a node population that either had a high tumor size or a tumor grade, and then cohort 2 obviously had high Ki67. And essentially, what we learned was that in patients with this high-risk N1 group in this real-world data set, there was a higher risk of recurrence, and that risk was doubled by almost 2 times than somebody who does not have that high-risk N1 disease. And the difference at 5 years was about 15%. So not only do we have the node positive as a risk of recurrence, but that node positive N1 group with higher risk features can have much more risk than your N1 with lower risk features. What about node negative? Just because you don't have nodal burden does not mean there is not a risk of recurrence. This is another example from a Concert AI Patient 360 database where women with early stage breast cancer, approximately a third of them, about 1,000 patients that had node negative disease, there was a high risk of recurrence at 5 years of about 22%, even in this node negative population. And similar to the node positive, not all node negatives are the same risk. There could be a higher risk node negative and a lower risk node negative. And we'll see that when we see the NATALEE eligibility criteria as well, because those were the patients that were allowed or eligible for the NATALEE population. Again, another real-world experience from the Flatiron database, there were approximately 5,500 patients that were N0 disease, of which 12% represented this high-risk N0 group. And then I'll draw your attention to the curves on your right. On the top is the overall recurrence risk. On the bottom is your distant recurrence risk. The teal ones in the middle, the dotted line is the high-risk N0 group, and the straight line, the bold line, is the N1 group. And you'll see they fare almost equally. So your high-risk N0 behaves like an N1. Your bottom one is your true N0 group with the low-risk N0 dotted line. So you have your high-risk node negative and you have a low-risk node negative. And then the mortality rates are listed on the table on the left bottom, where you'll see your high-risk N0 group mortality is similar to the N1 group. So with that in mind, let's look at the Monarchy and the eligibility criteria. Cohort 1 in Monarchy on your left were 4 or more positive axillary lymph nodes, or 1 or 3 nodes with that high-risk feature we were talking about, tumor size more than 5 or high grade. Cohort 2, which was 9% of the patient population, was 1 or 3 nodes with high Ki67, and their tumors were less than 5 centimeters and grade was less than 3. Now, NATALEE had a slightly broader patient population than Monarchy. In addition to the high-risk featured population that were included in Monarchy, they also allowed some node-negative patient population. So if you were node-negative and grade 3, you were automatically eligible. If you were node-negative and grade 2, you were still required to have some high-risk features such as high Ki67 or a high genomic assay score. This is the Monarch E design. The only things that I would love to highlight here predominantly is the randomization of nearly 5,600 patients was to get abemaciclib, which is a continuous daily dosing, 150 milligrams twice daily, plus endocrine therapy, which endocrine therapy could have included even tamoxifen or aromatase inhibitors, versus endocrine therapy alone. And with respect to the patient population, median age was about 51, 60% were N2 and 40% were N1, and 95% had received prior chemo. So this was really a high-risk patient population that had all received chemo as well. And now we've seen updated data from Stephen Johnston at the 7-year time point, so really mature data from the Monarchy, and you see that abemaciclib plus endocrine therapy reduced the risk of IDFS events by nearly 27% compared to endocrine therapy alone. And when you look at the rates of IDFS benefits, you'll see the curves are getting wider and separated more, and the absolute benefit now at 7 years is at almost 7%. This is the updated data for distant recurrence-free survival. Again, what you see is that the absolute benefit is about 5% here at the 7-year time point, and abemaciclib plus endocrine therapy reduced the risk of distant recurrence-free survival, really a meaningful endpoint, by 25% compared to endocrine therapy alone, and this benefit was observed across pre-specified subgroups. More importantly, what we really saw at the ESMO presentation by Stephen Johnston was not only have we seen distant recurrence-free survival, but also overall survival benefit, and the absolute benefit for overall survival is 1.8% at this 7-year follow-up or 6.3-year follow-up. And it reduces the risk of death by 16% compared to endocrine therapy alone. We saw some further subgroup analyses that were presented here at this meeting that we have included. This was by nodal status in the Monarch E group, and essentially you see this N1 high-risk group, which is your left column. You see more patients with Ki67 high, more than 20% in this group compared to the N2 and N3. Similarly, you also see a lot more grade 3, which is your red bar at the bottom left in the N1 high-risk group, 58% compared to what you see in N2 and N3. Adjuvant chemotherapy was seen more so in the N2 and N3 groups. And when we looked at the subgroup analyses by nodal status, consistent and sustained both IDFS and distant recurrence-free survivals were seen by this analysis. This is the Natalie trial. Again, we went over the eligibility. Differences here are it's a 3-week on, 1-week off regimen. Ribociclib dose is 400 instead of 600, which we use in the metastatic setting. And tamoxifen was not something that we can use just because there is a prolongation of QTC. With respect to patient population, median age is 52. Approximately 44% were premenopausal. Stage 2 represented 20%. Stage 3, 60%. Stage 2B was 20%. N0 is 12%. N1, 40%. And N2, 19%. Prior chemo in 88%. We also have updated data that was presented by John Crown at ESMO, where we see at 5 years there is an absolute benefit of 4.5%. The hazard ratio is 0.7. So with longer follow-up, again, durable IDFS benefit. We've also seen this IDFS benefit by nodal status. In fact, in the N0 group shown on your left, which represented 12% of the patient population, we're now seeing a hazard ratio of 0.6, and the confidence interval is now not crossing 1. Until now, we were seeing in that group that the confidence interval was crossing 1, and the benefit is sustained in the nodal negative group as well, the absolute benefit being 6%. We've seen disease-free survival, distant disease-free survival and distant recurrence-free survival benefits as well. They are sustained at this 5-year time point as well. You see 4.3 for distant disease-free survival on your left and 4% for distant recurrence-free survival on your right, which is very reassuring. Overall survival, the data are slowly maturing. There is a positive trend that we see with ribociclib and AI therapy. And this is continuing to emerge. The absolute benefit at this time point is 1.6%. So we'll continue to follow this. The hazard ratio is 0.8. At this meeting, we saw some subgroup analyses by anatomical stage. Again, no differences is the bottom line. We continue to see improvement in distant disease-free survival compared to endocrine therapy alone across all stages. And we also saw that this distant disease-free survival benefit was consistent regardless of nodal status and increased from 3 to 5 years as shown on the bottom. So you see the node negative and the node positive groups, the 3-year absolute benefit and the 5-year absolute benefit, and you see that increase from 3 to 5 years. This is a nice way of looking at this. This tells you patients living with metastatic disease, and you see how the CDK4/6 inhibitor have made a difference. On your left are the NATALEE data, on your right are monarchE. This is not for cross-trial comparisons, but compared to endocrine therapy alone, you're seeing fewer patients with metastatic disease or fewer deaths in both data sets. We know the toxicity profiles for both of these drugs, predominantly diarrhea, less neutropenia with abemaciclib, some LFT changes. We have 2 dose reductions with abemaciclib. With ribociclib, we have to monitor the QTc and the LFTs. We have 1 dose reduction because we start at 400 there. And when we looked at discontinuation rates, they were rather similar at 18 to 19% with both of these drugs, with LFTs that accounted for 8% to 9% with ribociclib. This was just looking at dose modifications by age. This is just to give you a sense of how many patients would require potentially interruptions and reductions. But when you see the age group of 65 and older, the discontinuation rates were higher. And even before doing a dose reduction, really underscoring the need for discussing, communicating with our patients how to manage these symptoms so we can have them report to us and we can dose reduce them before they discontinue therapy. Which tells us about Erica Mayer's effort on the phase 2 trait study. Just to give you context, patients by 12 weeks in the monarchE had discontinued, 10% of the patients had discontinued compared to 31% at overall 2 years, and 27% had required dose reduction. The trait trial is dose escalating abema, 2 weeks of 50 milligrams BID, followed by 2 weeks of 100, followed by 150 of another 2 weeks. And the primary endpoint to look at the composite AE rate or discontinuation for any reason or need to dose reduction in the first 12 weeks. And certainly with this dose escalation strategy, more patients were able to stay on therapy for a longer period of time in the first 12 weeks, which is a good thing to have. It's not like they're not going to have diarrhea by 12 weeks. You're still going to have that, but at least we're able to keep them longer with this strategy. The good news is if patients do require dose reductions, you can still have them maintain efficacy. We saw that in both monarchE and NATALEE, and quality of life is maintained with both drugs. So in summary, I think we're seeing with NATALEE and monarchE at 5 years and 7 years respectively, the relative risk reduction is similar, the hazard ratios are similar. We're seeing a larger absolute benefit at 7 years with monarchE and an overall survival benefit with relative risk reduction of 16%, which has been very meaningful.
Thanks so much, Komal. So, Seth, we've just heard the research. Now let's talk about some practice here. We have a 55-year-old patient of Dr. Toplinsky, ER-positive, HER2-negative, stage 2B, T2N1, interval-draining ductal cancer, gets neoadjuvant dose-dense chemotherapy, lumpectomy, adjuvant radiation therapy. Here's what happened.
After neoadjuvant chemotherapy, she had a left breast lumpectomy and sentinel lymph node biopsy. And the pathology revealed multiple small foci of invasive ductal carcinoma, with the largest focus measuring 4 millimeters in greatest dimension. And she received adjuvant radiation. She was postmenopausal. We started her on endocrine therapy with anastrozole and then added in abemaciclib. And a question here is choice of CDK4/6 inhibitor. How are we making the decision between abemaciclib and ribociclib in a patient who is eligible for both based on the monarchE and the NATALEE trials?
Could you kind of provide an update on where she is right now?
She is doing well, but did need a dose reduction of the abemaciclib due to gastrointestinal side effects, mainly diarrhea. So she started at the 150 milligrams twice daily and is now on 100 milligrams twice daily. And we saw at ASCO some data about doing an up titration of abemaciclib. And a question here too is how many people are doing that? And are we starting at the 150, decreasing as needed, or up titrating from the 50 and following that protocol?
So, Seth, a patient like this, 2 years of abema or 3 years of ribo, and if you're going to give abema, do you like the up titration?
This is a key question that comes up a lot because there is significant overlap between the two populations. Everybody who is eligible for monarchE would also be eligible for NATALEE, though NATALEE had this broader inclusion criteria that allows us to treat some of the higher risk N0 or slightly lower risk N1 patients. For me, If a patient meets only criteria for NATALEE, that's a relatively straightforward. If the patient meets criteria for both, I tend to prefer using abemaciclib. We just saw a very nice overview of how mature that data is. Now, it's not quite as straightforward as it seems. We're not just looking at the total amount of follow-up. We really want to see the total amount of follow-up once everybody is off drug. So not only does NATALEE have slightly less total amount of follow-up, but because it was a 3-year duration, the absolute amount of time when everybody comes off drug is even less compared to monarchE. And if you go back to the Penelope B study, which was a relatively high-risk group of patients who had preoperative chemotherapy, residual disease, they had 1 year of adjuvant palbo. The curves began to separate by a couple of percent. Everybody came off palbo and they came together. To me, that suggests that there's probably micrometastatic disease that's there that we haven't eradicated. We've just delayed outgrowth. Whereas here, as we just saw for monarchE, everybody comes off drug. The curves not only stay far apart, but they actually are continuing to separate further, suggesting that you have micrometastatic disease that you may have cured or eradicated, and we're starting to see that with overall survival. So due to the duration of follow-up off drug, due to the positive overall survival data, I tend to prefer abema. Now, the trade data is very reassuring to me. In my practice, as of a couple of months before that, I would typically start at the standard dose, and I would have a low threshold for dose reduction due to the data we saw about magnitude of benefit with dose reduction. I think the trade data is very reassuring, and it's similar conceptually to neratinib, where we have the same issue. We had a lot of diarrhea. It tends to occur in the first 4 to 8 weeks and then subside. If you can get them through that period, they tend to do better over the longer term. The tough part about this, though, is it's kind of hard to write these orders. You have to write like separate orders for 50 and 100. I would love to have like the starter pack like we have for neratinib, where you could put one order set in, the patient gets it, and then they can just easily take the doses.
Hope?
They're producing exactly that. 2 weeks, and that gets free, but only once.
All right, I want to go to another case. So, Erica, we really appreciate when docs talk about their cases when there's no clear answer. This is a very interesting situation Dr. Fox faced of a 67-year-old woman, ER-positive, HER2-negative disease. She's a heavy smoker. He was screening her for lung cancer. She was doing great on adjuvant letrozole and pops up with a lung mass. And you actually thought it was going to be a lung cancer. Either way, she didn't have any other disease. Sent her for resection. Here's what happened.
She was a former smoker, so we had been getting low-dose CTs on her. She had an enlarging left upper lobe nodule. It had become more PET-avid, as you can see on our scans right here. Ultimately, without any evidence of disease elsewhere on her PET scan, she was referred to thoracic surgery and underwent a resection. The pathology showed that this was an advanced breast cancer. She had no other evidence of disease on imaging. My approach to her was that I did change her aromatase inhibitor to Faslodex, and I started her on a CDK4/6 inhibitor. I used abemaciclib. My questions for the experts here are, how do you approach a patient that develops a limited metastasis that's dealt with locally while they're on their adjuvant aromatase inhibitor? Would you send for circulating tumor DNA?
So, Erica, when we get to the GI meeting in January, we'll be talking a lot about circulating DNA and colorectal cancer. Any thoughts about this case?
Yeah, so I think that, first of all, this patient has metastatic disease. We might call it oligometastatic, but it is distant metastatic disease. And so I think that as soon as that diagnosis is made, we are shifting our treatment goals, we're shifting our paradigms into that space. It feels very appropriate that the patient had this small lesion resected because there was certainly a high chance it could have been something other than breast cancer. Now that it's not there, technically she's what we might call NED, but she still has metastatic disease. So I agree that I would change her systemic therapy to the treatment I'd want to give for first-line metastatic, changing her endocrine therapy and adding a CDK4/6 inhibitor. I do think it would be worthwhile to get tumor genomic profiling, as that's what we do when a patient's diagnosed with metastatic disease. And so certainly one could send ctDNA, although in the setting of having very low volume disease, it's possible that the fraction of ctDNA in the sample might be very low to undetectable. And so our other option is to test the tumor tissue itself, and that would provide some guidance as to whether there are any actionable mutations present. And then I would plan to test again at a future time of disease progression.
Komal?
Yeah, no, I think I completely agree with Erica's comments in that, it's oligometastatic disease. Technically, it's no evidence of disease, but it's still, oligometastatic distant recurrence. And I would test the tissue just to get a sense of what have we learned from that tissue to see what kind of profile might be applicable. But I agree with the management that was laid out by Dr. Fox.
All right, Hope, let's talk a little bit about upfront treatment for hormone receptor-positive HER2-negative disease, CDK inhibitors, but also PIK3 therapy, the triplet.
Okay, so upfront treatment paradigm for HR-positive HER2-negative metastatic disease. The areas that I'm going to cover are, the data that we now have telling us more about chemotherapy versus aromatase inhibitors and CDK4/6 inhibitors in patients with high-risk features and newly diagnosed untreated metastatic breast cancer. We really want to look at that evidence and see where we've landed with new evidence presented today. Also, we now can use biomarkers to drive the treatment approach in the first-line setting, targeting PI3 kinase, and in some patients, like the one we just talked about, potentially targeting emerging ESR1 mutations. So let's talk up first about the chemo versus CDK plus ET situation. So the right choice actually was a fascinating trial. It was done in countries that have often used chemotherapy more than, say, in the U.S. and overall in Europe and Canada, including Canada there. And so what they did was say, okay, because the idea was young women, they don't have this endocrine-sensitive disease, despite the fact that Richard Pito showed that they did. So pre- and perimenopausal women, they had no prior systemic therapy, measurable disease by RECIST, and then they had to have what they called visceral crisis, but wasn't visceral crisis. It was symptomatic visceral metastases, rapid disease progression, or markedly symptomatic non-visceral disease like bone mets. And in fact, they couldn't have an elevated bilirubin, more than 1.5 times the upper limit of normal. So the patients that we would call visceral crisis wouldn't have qualified. They randomized 222 women to receive ribociclib letrozole with ovarian function suppression or combination chemo, which was, again, a long-standing thought that it's better in this situation. Docetaxel cape, paclitaxel gem, cape vinorelbine. And then they evaluated these patients over time, median age of 44, de novo disease in 65%, which is really high, and visceral mets in almost 80%. They thought there was visceral crisis in 52%, for what it's worth, or symptomatic visceral mets in 67%. It was really fascinating when we saw this data presented. What you can see here when you look at the progression-free survival is that it was significantly better when patients treated with ribo-ET versus combination chemo, highly statistically significant, hazard ratio 0.61. And the time to response was actually a little bit faster because one of the arguments had been, if you give chemo, you respond faster, so that's better. But that wasn't the true. And so the time to response hazard ratio crossed 1. There was really no difference, although it trended towards ET ribo. The overall response was a little bit better. There was more neutropenia, of course, with ETR, but a lot more side effects with chemotherapy, as you would expect. So that, I thought, was very definitive data, but it wasn't because some people still get chemo. So then we saw the PADMA study. This was presented last year in San Antonio. And in this, it was really investigator choice. So patients who had an indication for monochemotherapy, again, untreated, no asymptomatic bone-only disease or oligometastatic disease, no brain mets. So patients were randomized to receive endocrine therapy and palbo of any age, so 150 patients, not just pre- and perimenopausal, or monotherapy with chemotherapy, and the options are listed below on this slide. If you didn't tolerate the chemo very well, you wanted to stop, you could go on endocrine therapy maintenance. And you could get an AI or fulvestrant with ovarian function suppression as needed, and tamoxifen in patients who couldn't tolerate it. Here you can see this remarkable data, again, with a median time to treatment failure much longer, 17 versus 6 months for palbo-ET versus chemotherapy, hazard ratio 0.46. And you can see in subset analyses, liver mets, more areas of disease in the body, so more sites of disease. None of these actually correlated with a worse outcome, starting with ET and palbo. They also looked at progression-free survival rate here, not just time to treatment failure, and overall survival. The median overall survival was 46 versus 36.8 months, but it wasn't a primary endpoint, so they couldn't do a hazard ratio. But I think it's really fascinating data. So then today we saw Veronique Dieras present the OMBRE trial. So here they just were responding to a little bit of frustration about the eligibility for right choice and thinking maybe they could get sort of honed down here. So patients were eligible in first line, high tumor burden. So they wanted to define high risk. So 2 or more visceral sites or 3 lesions in 1 visceral site or more, or 1 visceral site and a high LDH, which is correlated with poorer outcome. Patients could receive capecitabine paclitaxel and then followed by maintenance ET and abema, or they could start with ET and abema with ovarian function suppression as needed. And they also looked at circulating tumor cells, interestingly. So 66% of the patients received CAPE, 34% received paclitaxel, most of the patients received an AI, and a quarter received fulvestrant. And then about a fifth of the patient went on from chemo to go on to endocrine therapy maintenance. So very interesting. Here, the de novo de novo disease was 27%. And you can see that I've listed here the percentage of patients with various settings. Mostly it was more than 3 lesions in 1 organ at 63%, but 77% had liver mets. So what happened? Here you can see again, median progression-free survival. This is reversed from the way we saw it in others, but standard chemo is 7 months, 13.9 months for the abemaciclib and endocrine therapy. No difference in response here, but longer duration of response, and 19 patients crossed over from standard chemo to ET at 6 months. They also saw a better drop in circulating tumor cells with the ET versus chemotherapy, as you can see when they tried to look at less than 5 as the cutoff, 64 versus 83% with chemo, and chemo was more toxic. So I figure that this is 3 trials. I think it's pretty now confirmed that you can give endocrine therapy and a CDK4/6 inhibitor with either ribociclib, abemaciclib, or palbociclib, depending on your choice of therapy and all our other data, rather than giving chemotherapy, unless patients really have pending liver dysfunction, they're hypoxic, or have, neurologic crisis. Otherwise, this really does confirm it's a better option to give patients endocrine therapy and a CDK4/6 inhibitor. And then lastly, there's a trial called Abigail that was presented at ESMO a year ago. This was updated data, and they gave a paclitaxel induction to see if that was better, followed by abema or an endocrine therapy versus starting with the abema and endocrine therapy up front. And what they saw in these patients who had higher risk disease was that their endpoint was 12-week overall response, was better if you gave abema letrozole up front than if you gave 12 weeks of paclitaxel, which again, I think is really encouraging. And of course, you didn't get any neuropathy if you started that way, which was kind of nice since that's a lasting toxicity. Now, how we choose the CDK4/6 inhibitor we give in the first line, of course, is lots of data here, but you can see palbo, ribo, abema, and we really kind of mostly give ribociclib now because of the OS data in the phase 3 trials, both in the first and second line setting. I think abemaciclib we tend to give in the second line setting because of the diarrhea, although we give it a lot for early stage now. And then palbo, we have real world data showing that there's similar outcomes, but there are various issues in terms of follow-up and the number of patients in each group, that this is our p-verify with similar overall survival. So we tend to use palbociclib in patients who don't tolerate ribo or who are older and need maybe a gentler approach. So our decisions are really based on different patient populations. That impacts the results from phase 3 trials, cardiac issues, liver enzyme abnormalities, GI conditions, disease burden, genetic mutations in some settings, and duration of disease control on prior therapy. So what about patients who have PIK3CA mutations and early relapse? These are patients we've really worried about, patients who have relapsed while on their adjuvant endocrine therapy or within a year of completing it. So Anavo 120 actually treated this patient population based on murine model, very strong murine model data, who also had evidence of PIK3CA mutations and measurable disease, to receive inavolisib, palbo, and fulvestrant versus placebo, palbo, and fulvestrant. And the demographics are listed down here with 80% visceral metastases. And adjuvant, interestingly, 38% of Asian patients, 48% received adjuvant tamoxifen, one of the questions here. So they found the PIK3CA generally in blood with ctDNA, and the most recent data presented at ASCO and published in the New England Journal by our very own Dr. Jhaveri shows a significant improvement in overall survival with a p-value of 0.019, and you can see that the number of deaths is different by 10 deaths median significantly different of 6%. And the median follow-up is now just 3 years. So this is very impressive 7-month difference here in overall survival overall. They also updated the progression-free survival, time to first subsequent chemotherapy, all significantly towards giving inavolisib. You can see that big difference in progression-free survival without really a fall-off. The curves separate early and stay separated over time with an absolute improvement of almost 10 months in median progression-free survival. Overall response was better, as was duration of response from 11 to 19 months. So very impressive data. What's important in using this triplet combination is managing toxicity. Patients were not eligible if they had hyperglycemia or abnormal hemoglobin A1C, with the exception of very slight increase. So there wasn't a lot of hyperglycemia that was grade 3 or 4, but now we're actually starting trials that will manage patients who have prediabetes or type 2 diabetes to try and better manage this. There is some stomatitis we treat with steroid mouthwash, and of course neutropenia from the palbociclib. So you have to screen patients carefully for inavolisib and manage their glucose. SERENA-6, as you know, is a switching study, and I think everybody's aware of the data here where patients were screened who'd had at least 6 months of endocrine therapy and a CDK4/6 inhibitor with serial ctDNA. And when they developed an ESR1 mutation without evidence of disease progression, they switched to camizestrant, the oral SERD, but they stayed on the same CDK4/6 inhibitor. We saw the updated PFS today with a difference in median PFS of 7.4 months and an updated PFS2, which I think was also interesting, showing a significant difference now, which had not been shown before. And the time to next chemotherapy and first subsequent therapy was also better. And I think this data, which was shown at ESMO by Erica Mayer, showed that we had seen initially that the time to deterioration of global health status quality of life was better with the switch, but we saw that that was largely due to a difference in pain. And I think that's quite compelling data, actually, overall in this quite controversial area. And there was better chemo and antibody drug conjugate survival, so free survival. And then there are a number of trials going on. We're going to see a lot of this data coming up in the future in the metastatic setting, first line, second line, in combination with other agents targeting CDK4 and targeting PIK3CA with triplet therapy. So I'll go on because of time and just say that, we've seen a lot of new data in the metastatic setting and have new treatment approaches, and SERENA-6 is still an area of high controversy.
Thanks so much, Hope. So, Komal, I was thinking about you, Hope, and Virginia Kaklamani when we saw the lidERA trial go from press release to being presented here. But I think you guys set the world's record 2 years ago with the Nava 120. We actually have a case related to that we'll get into with the next module. Angie, also, I know you discussed the SERENA-6 study. I want to let you know we have a poster here. We have 4 posters, all kinds of surveys, but one of them asked docs about SERENA-6. We found a third of the investigators said they actually wanted to use this strategy, whereas the majority did not, as per your discussion. But interestingly, 2/3 of general medical oncologists said they would like to use this strategy. So a little bit, and Seth worked with us on that survey. But I'd like you to respond about the issue of selection. Hope brought up the issue of, being kind of liberal and how you approach the selection of CDK. I'd like you to listen to Dr. Gandhi, who has an 80-year-old woman, type 2 diabetes, well-controlled hypertension, metastatic disease, after 4 years of adjuvant letrozole. He gave her a palbo, and I said, well, did you bring up the issue of, ribo with survival benefit, et cetera? Here are his thoughts about choice.
We all are well aware of data on ribelosib and overall survival. Question is, in elderly patients, it does become a significant issue of tolerability. And many of them have significant cardiac problems. I know the overall survival, but quality of life supersedes overall survival in that case. And I usually go with palbociclib. And question is that what faculty would advise too? And I have good luck. Many patients living for 4 or 5 years. And then 8 is when they live 4 or 5 years of good quality of life. They are extremely happy. So I want to know what faculty thinks about that, in particularly elderly group. If it is 50-year-old, 55-year-old, everybody would go with ribosibulin.
And, we also get involved the patient in the decision. Any thoughts, Angie?
in this situation, quality of life really is our most important consideration. And particularly for an older patient who has lots of comorbidities, I think we really have to think about what the burden is going to be of taking each of these different medications. Diarrhea that makes it impossible to leave the house is really terrible for these patients and limits their ability to participate in life. Many have concerns about cardiac issues. We have to be careful about liver function with ribociclib. So I do still use palbociclib. I think it's a good drug. It does have, for some patients, a very long period of response. But we do talk about the limitations in the data. I just think that for a patient who's 80, overall survival may not be their number one priority. And this is where we really have to understand what their priorities are.
Kamal?
Yeah, no, I think completely agree with Angie that that's how we would approach this here. The 2 points that I'd make is that, yes, overall survival is very important, but we cannot forget that all these trials were really set out with the primary endpoint of progression-free survival with identical hazard ratios across all 3 drugs. And so I think it's very okay to think that all 3 drugs are going to work really well for this 80-year-old. You know, we have more medications when patients are getting older, and the drug-drug interactions can increase more. That's one thing that we have to remember. And so choice of CDK could depend on that, depending on what drug-drug interaction could lead to. But last but not the least, we're also seeing a lot of data that says that, you know, it's the elderly patient population who have the same efficacy, but maybe the grade and the severity of toxicity is much higher. And this is where, you know, you could start them on a lower dose and keep them at a lower dose. And that's really important for us to remember that despite dose reductions, efficacy was maintained. So in this patient population, regardless of what CDK4/6 inhibitor you choose, I think it's okay to even consider starting them at a lower dose because they might not necessarily be able to tolerate the full dose.
So a final comment from Erica. Spoiler alert, our last patient is 103.
Wow.
So just to follow on that, there's a trial for that. And ASCO is actually running the first prospective therapeutic trial that ASCO has ever run, specifically looking at this question of dose escalation of CDK4/6 inhibitors in elderly patients. It's called the ASCO CDK study, and patients are randomized to start their first-line endocrine and CDK at the sort of standard dose or at a low dose, and you escalate it as you and the patient are comfortable. So again, I encourage, if you have that trial open, that's a great way for us to study and demonstrate that this is probably the preferred way to do it, as I think some of us are exploring.
All right, well, just keep going, Erica. Now we're going to talk about PIK3 AKT and mTOR.
Okay, thank you. So just kind of bridging off of what we just talked about with the Inava 120 study, I want to move into talking specifically about post-CDK4/6. What is the role of agents that target the PI3 kinase pathway? Just a reminder, currently we have 2 approved regimens in the post-CDK setting. This includes alpelisib with endocrine therapy, as well as the combination of fulvestrant and capivasertib. We're going to talk about that in more detail, as well as an emerging, what we call PAM pathway inhibitor called gedatolisib. So let's jump in, and we're going to first just talk a little bit about why this is important. So the PI3 kinase AKT-mTOR pathway, or PAM pathway, is frequently altered in hormone receptor-positive breast cancer about 40% of the time. This is important because when this is activated, there can be uncontrolled signaling through this pathway. And in cancers that have this, in combination with unregulated signaling through the estrogen pathway, this really presents an opportunity for us to co-target with a combination of an endocrine agent and an agent targeting the PAM pathway. And this has been a successful method to try to control cancer. So just as a sidebar, what is the best way for us to identify a PI3 kinase mutation? When we are doing tumor genomic testing, as we discussed previously, sometimes we do this as a tissue-based assay. Sometimes we do this as a blood-based assay using ctDNA. And importantly, PIK3CA mutations are what we might think of as truncal. They are present when the cancer is born. So this means that this is present in the primary disease, this is present in the metastatic disease, and can be present in ctDNA. And so when we're thinking about tissue testing, although we often like to test the metastatic biopsy, just a reminder that if you don't have that tissue, you can go back to the original primary tissue for testing. Importantly, although on the one hand, for example, with ESR1 mutations, those may be preferentially tested through ctDNA, with PIK3CA, it actually is perhaps preferred a bit to test with tissue, as we have discordance, as shown by the little blue line in that figure, where the tissue can be positive and the ctDNA can be negative. We actually saw some data today in one of the rapid-fire sessions suggesting to us that when we are testing for PIK3CA, about 10% of the time you miss it with either type of test. So we could be missing it 20% of the time. That's why in my practice I like to test both when a patient is first diagnosed with metastatic disease and then use ctDNA moving onward. So let's jump into Capitello 291, and this is the study that led to the FDA approval of the regimen of capivasertib and fulvestrant. This was a trial for pretreated metastatic breast cancer who had had up to 2 prior lines of endocrine therapy, up to 1 prior line of chemotherapy, plus minus CDK4/6 inhibitor. Importantly, no prior PAM pathway inhibitor was allowed, and patients could have a hemoglobin A1C up to 8. So this is a little more liberal than some of the other studies as we just mentioned. Patients are randomized 1-to-1 to receive capivasertib and fulvestrant or placebo and fulvestrant. Remember, capivasertib is dosed 400 milligrams twice a day, 4 days on, 3 days off. So you could say to a patient, you can take it like Monday to Wednesday, and then you have the long weekend off. There are dual primary endpoints for the study, progression-free survival in the ITT, the overall population, and in the population of patients whose tumors have an AKT pathway mutation. So this is a positive study. It actually met both primary endpoints in the ITT population with a hazard ratio 0.6 and in the AKT-altered population with a hazard ratio of 0.5. And that's what ultimately led to FDA approval in patients who have a AKT pathway-altered tumor. Now, it's important to consider the side effect profile of capivasertib. Some of the common toxicities that one might encounter include diarrhea, nausea, or rash. And these are toxicities that can be managed with supportive care, including early use of antidiarrheals or antihistamines. And we have a lot of interest in looking at prophylactic strategies to make capivasertib a more tolerable agent. So now let's turn to the new kid on the block, which is gedatolisib. So gedatolisib is a PAM pathway inhibitor. This means that it is targeting PI3 kinase, AKT, and mTOR, and you can see in this figure that it's inhibiting all 3 of those, and that's quite different than alpelisib, which is PI3 kinase only, capivasertib, which is AKT only, or everolimus, the classic everolimus, which is mTOR only. And so gedatolisib has been studied in a phase 3 trial called Victoria-1, which was just presented at ESMO a few months ago. So Victoria-1 is a study for patients who've progressed on prior CDK4/6 inhibitor, up to 2 prior lines of endocrine therapy, no prior chemotherapy, and no prior PAM pathway inhibitor. Patients could have a hemoglobin A1C up to 6.4, so a little more stringent in this trial. Now, Victoria-1 has 2 parts to it. Study 1 is for patients who have cancers that are PIK3CA wild type. This is the part that was reported at ESMO. There's a second part, which is for patients whose cancers are PIK3CA mutant, and we are still awaiting results from that. So in Study 1, patients were randomized to one of 3 arms. There was a triplet of gedatolisib, palbociclib, and fulvestrant, a doublet of gedatolisib and fulvestrant, or fulvestrant monotherapy, and there was an optional crossover to arm A or B at progression. Now, notably, gedatolisib is an intravenous medication, so it is given IV once weekly, 3 weeks on, 1 week off. Palbociclib and fulvestrant were given as we traditionally do. There were co-primary endpoints of the study looking at progression-free survival in arm A versus arm C and arm B versus arm C. So what was shown from Study 1, the PI3 kinase wild-type group at ESMO, was that the study met both primary endpoints with substantial prolongation in progression-free survival with both the triplet versus fulvestrant and the doublet versus fulvestrant. I'll point out that the progression-free survival on fulvestrant was only 2 months, and I think this really shows us that we increasingly recognize that there's little role for endocrine monotherapy in the treatment of patients post-CDK4/6, and that we really want to be reaching for doublets or even triplets in this setting so that we can target multiple pathways of endocrine resistance. Overall survival is immature, and yet you can see from the figures on the bottom that it is trending favorably for both the triplet versus fulvestrant and the doublet versus fulvestrant. This is looking at progression-free survival in key subgroups, and I think this is very important to see that the benefit of the triplet or the doublet versus fulvestrant was important in both younger patients, premenopausal, in patients in the US or Canada, in patients with visceral disease, in patients who had had shorter prior duration on their therapy before entering the study, and very interestingly, in patients who came into the study after prior palbociclib. I find this quite interesting because having led the PACE study, which was palbo after palbo, and that showed no benefit in continuing the same CDK4/6 inhibitor, here it is the same CDK4/6 inhibitor, it's palbociclib, and yet when used in these combinations, perhaps we're getting additional benefits and we're moving beyond just CDK4/6 inhibition into this multi-targeted inhibition, and we're seeing this very nice benefit. This is looking at overall response rate, and we can see robust response, 39% with the triplet, 32% with the doublet versus essentially 0 with fulvestrant. And duration of response was also prolonged, 17 months with the triplet, 12 months with the doublet. In terms of safety and tolerability, gedatolisib has a few side effects to be aware of. First of all, the drug can cause stomatitis, and rates of stomatitis were between about 60 to 70% all grade, with about 20% grade 3. I will say that use of steroid mouthwash, as we often do with mTOR inhibitors, thanks to Hope's research, was mandated in this study. So we did see stomatitis despite the use of steroid mouthwash. Rash was about 30% all grade, much lower rates of grade 3 rash. Importantly, though, rates of discontinuation of therapy were very low, only about 2%, suggesting that with appropriate symptomatic management, dose holds, and dose reductions, patients were able to continue on their medication without having to discontinue. I will also add that we did see additional data today at one of the rapid-fire sessions, digging a little bit deeper to the Victoria-1 data, showing us that the mucositis that we see with gedatolisib tends to occur about a week after starting, and once the drug is held, it takes a couple weeks for it to go away. So that gives us a good sense of the rhythm of it. So I'm showing you a figure that actually I've borrowed from Seth, or modified from Seth, that looks at the toxicities across the PI3 kinase pathway inhibitors. And we can see the 4 major toxicities we might encounter, including hyperglycemia, diarrhea, mucositis, and rash. The shaded gray boxes would be the winner, the one that has the lowest levels of toxicity. And we can see that gedatolisib, compared to the other agents, has the lowest rates of hyperglycemia and of diarrhea. Capivasertib has the lowest rates of mucositis, and inavolisib the lowest rates of rash. I think we see here that alpelisib, unfortunately, doesn't win in any of those categories, and that might be why, for many of us, we've moved away from using this routinely in clinic. And so just a look ahead at the future, what I think we're all looking forward to is the use of mutant-specific PI3 kinase inhibitors that selectively target the mutant PI3 kinase in the tumor and spare the wild-type PI3 kinase in our normal liver or muscle, and that helps to avoid some of these common toxicities. And there's 2 exciting agents, an agent which we've called the relay compound, now we call it zovegalisib, and a scorpion lily drug called tersolisib. And both of these agents are in phase 3 trials right now, so definitely something to keep your eye out for. So if we go back to our original algorithm, and I'm going to modify it based on some of the data you're about to see from Seth, I think based on what we've seen in the past year and at this meeting, we can see that we have a lot of emerging and exciting agents, including the Serena-6 regimen that we talked about, some of the oral SERDs we're going to talk about, but I will point out that the data with gedatolisib is definitely exciting in the non-mutant population, and we'll look forward to seeing the data from the study 2 from Victoria-1 to see if this regimen could be a potential option across the board.
Thanks, Erica. And speaking of CAPI, there was actually a positive phase 3 trial at ESMO presented of CAPI and abiraterone in hormone-sensitive metastatic prostate cancer. We actually did a program at the AUA, American Urologic Association, on this. We used video from Hope, who was nice enough to work with us to explain to the urologist what's involved in using CAPI. That was actually P10 deleted, incidentally, which actually is a poor prognostic marker. In the control group, these patients progress in 2 years, which is very quick for hormone-sensitive disease, so we'll see where that plays out. But I hope I am curious of what your thoughts are about this new agent, gedatolisib. As Erica was just saying, here's some of the data she just referred to, presented here from the Victoria-1 study, and here's what she was just talking about in terms of the timing of stomatitis. Looks like, again, here's what happened in terms of glucose. It looks like this is not really a major issue, and of course, the thing that's really interesting, Hope, is this PIK3 wild type. So what do you think we'll see with PIK3? I assume this is going to be looked at with PIK3 altered disease, and what are your thoughts about this?
Yeah, I mean, I think we were really impressed by this data. I had participated quite a lot in the phase 1b, phase 2, little bit of phase 2 data that we had with gedatolisib. Then it was called jedatolisib. But anyway, Jedi Warriors. But that's how we remembered it. But and I was really impressed with it then. And we had just started using CDK4/6 inhibitors, and we were giving triplet, and people would just stay on who had very advanced, heavily pretreated disease. So it was quite gratifying to see this improvement. I think what we don't know is how much the added benefit from the triplet versus the doublet is worth the added toxicity, which is a 7% increase in grade 3 stomatitis, and just more overall, I think, toxicity. Although, as you pointed out, the discontinuation rate was very low. The efficacy is very good. I think we'll have to see what the triplet and doublet do in the PIK3CA wild-type population. And then there's a trial, Victoria 2, looking at this in the first-line setting, and that will also be fascinating. I remember at ESMO, we had various little meetings and talked to people around the world about the difficulty of getting IV therapy, because people say, oh, well, I wouldn't get IV therapy. But actually, a lot of people were like, that's not really a big deal for the patients. They can... maybe it is in LA, but I think in other parts of the world, I think a lot of times people would not mind getting IV therapy, and it's a peculiarity of U.S. Medicare that it would be cheaper for patients than getting an oral therapy as well. So I do think it has a lot of potential as we continue to follow this data.
Really interesting. All right, Komal, I'd like you to listen to this case of a 68-year-old woman, ER-positive, HER2-low, PIK3 mutant disease, who has disease progression after 2 years of adjuvant letrozole, and then a comment about the triplet.
Unfortunately, 2 years into her adjuvant endocrine therapy course, she developed a metastatic recurrence with mets seen in the lung, bone, as well as the liver. And this was biopsy confirmed, and molecular testing on the tissue revealed a PIK3CA mutation. One of the treatments we discussed was fulvestrant, palbociclib, and the addition of inavolisib. Which patients would you consider for this treatment approach? What's your experience with the tolerability, and any suggestions on management strategies to address and reduce the chance of some of these toxicities? Do you find it adds a lot of side effects or additional impact to quality of life over a fulvestrant plus CDK4/6 inhibitor approach?
Did you actually recommend the triplet to her?
I did. However, we did a staged approach where we first initiated fulvestrant and palbociclib. One of the major issues that we have managing these targeted therapies is hyperglycemia. And, I'm in Kentucky, we have high rates of diabetes, and this can really be very limiting. And curious to hear from the faculty, do you actually initiate a medication like metformin up front? Do you prescribe home glucose monitors for patients? What have you found to be the best approach to managing the hyperglycemia?
I will very clearly tell you I have come to avoid alpelisib at all costs. I've treated one patient on the Inovo cocktail, and I found that to be, at least in my N of 1, a kinder, gentler drug in that pathway. I find the CAPI is very manageable.
Komal, any thoughts?
Yeah, no, I think very good question. So I think I would agree that the eligibility was for endocrine-resistant patient population, which is where the label is currently, and that's how I think about it. So this is for patients who have had recurrence on or within 12 months of their adjuvant endocrine therapy, such was the patient that Dr. Agarwal was talking to us about. And certainly, the trial specifically allowed patients to be eligible if the hemoglobin A1C was less than 6 and the fasting blood glucose was less than 126 milligrams per deciliter. So this is really tight glucose control, which could be difficult. And that's, we're talking about a smaller group of patients which are endocrine resistant, and then really talking about what kind of criteria we need to make sure that the hyperglycemia rates are not high with. Thankfully, we have some data from, say, the Metallica trial, which was a Spanish effort that looked at prophylactic metformin. So it's like ramping up your metformin for the first 2 weeks before you actually bring in the PI3K inhibitor on board. Lifestyle modification has been a big thing that we have been talking about in cancer in general. We have so much data now with exercise, but really, really important with this pathway drugs where hyperglycemia is seen, that we talk to our patients about lifestyle modifications and diet modifications so that we can keep their glucose under control. So in patients where there is a higher risk, which would not have been eligible in AVO 120, but I am certainly worried about their disease and how the control arm did so poorly, and we've seen an overall survival benefit, I would try and at least, do these lifestyle modifications. Definitely consider prophylactic metformin in those patients. Sounds like this patient was already a diabetic. Maybe they were already on metformin. I would have probably even given them one more medication if I needed to. Home glucose monitoring has been helpful. I have actually done continuous glucose monitoring. Many patients love doing that better, and I think it's easier to control. And as long as they keep the levels no more or higher than 250, then I think that has been a good approach to keep this under control.
Yeah, I mean, the home monitoring thing, too, also gives you a hemoglobin A1C and percent time within normal range. And also, and Hope, maybe you want to comment on this. When we do surveys, we ask people, would you offer the triplet? And some people say they do it for de novo, which is not endocrine resistant. No. And then the other issue is now you're talking about testing up front, where people kind of got the message from ESR1, you wait until recurrence. Any thoughts, Hope?
Well, so I use the label approach. I wouldn't treat a patient at de novo or a patient who had no evidence of upfront endocrine resistance, but that's being studied in AVO 123 and a number of other studies, as I mentioned, including Piccolo, and I think other studies have this as an added criteria. But I did use the triplet, and a patient from Mexico who came, had got one dose of fulvestrant, and they ran out of fulvestrant. So she came to LA, and we did all of her diagnostic stuff again because it hadn't been done, and she had a PIK3CA mutation. So we put her on Palbo and AVO, and she's only in her 60s. Her hemoglobin A1C was like 6, so I put her on metformin to start with, and it just was like neutropenia, hyperglycemia. It's an interesting thing. I mean, you really have to work with the patient, have a lot of education, and I do think in this situation with somebody who generally had poor healthcare literacy, that it was really a challenge. And so we dose reduced both medications, and then she just got admitted for pneumonia and came in hypoxic and febrile. So, this all related to drug. But the good thing about it is that she was having severe pain and couldn't walk. And within less than 7 days of starting the medication, her pain was gone. So it's a balance, and it's tough. I think I would start a patient like that on lower doses next time, but she was on the lower doses now for 2 months, so it can be a challenge.
So Hope was nice enough to hook us up with Dr. Neil Pazrica, an incredible ophthalmologist. We did a program on ophthalmology for the oncologist, and now we're working on a program on diabetology for the oncologist. So
and we need it.
We know about cardio-oncology, but before we get into it, maybe we can have Erica comment. But first, maybe you can take a look at this case, because I think now you're really getting into more of the nitty-gritty about using these agents. This was a patient, when she was initially presented to me, she said, she just got CAPI for 3 months and then progressed. But then when we pursued it a little bit longer, more, it was kind of interesting actually what happened. So Erica, here's what happened. Any questions about your 63-year-old woman with a PIK3 mutation who has disease progression on Palbo fulvestrant?
I'd like to hear how people make the decision between capivasertib and alpelisib.
Could you tell me how she did on the CAPI?
The biggest side effect she had was hyperglycemia, and so did require some dose holds from that. One of the reasons she was only on it for 3 months before having disease progression was due to some frequent hyperglycemia dose holds and reductions.
Do you happen to know what her hemoglobin A1C was?
Yeah, so her hemoglobin A1C initially, when we tested it before starting capivasertib, was about 7.2. And so I did send her to an endocrinologist who put her on therapy and did clear her in a way to begin capivasertib. But that still, despite being on therapy and despite following closely with an endocrinologist, we were not able to adequately control her hyperglycemia.
Yeah, she was not a known diabetic. I saw Kamal's eyes get very wide when she heard that 7.2. Any thoughts, Erica?
Yeah, that's tricky. I mean, Eleanor did all the right things and, checked the labs beforehand, ensured the patient's eligibility, looped in an endocrinologist, got ready for it. And, so I don't think there's anything more she could have done to help prevent that situation. But what I was going to add just about both CAPI and Inavo is, this isn't just like the doctor managing what's going on, but it's our teams. And we have to educate our APPs and our ONNs and all the other people who are involved in the patient care. I routinely tell my patients to buy a glucometer, which are like $30 on Amazon, so it's easy to have, and check their blood sugar, and they call in with it so we really know what's going on, or continuous glucose monitoring. But those phone calls are coming to our teams, and they need to be empowered to know how to manage it and answer those questions and keep moving and keep making the modifications as we need to. Because we see there's a benefit to staying on these drugs, but we just have to figure out how to hit the sweet spot so the patient can tolerate it and also feel like they have all the support they need.
Angie?
Yeah, I just want to second that. I think we have done a lot of training of our teams. We have algorithms. We have little cheat sheets that all of the staff use so that we can be on top of what's happening with these patients. Of course, you want the patient to be able to call in and let us know what's happening, but they're not always going to do that. And we do need to track and make sure we're checking in with the patients. And I agree, I do the glucose monitoring as well. Much easier than having them come in and get blood draws, which is what is typically recommended.
Komal, final comment?
Yeah, no, I think I just wanted to add, I think the hemoglobin A1C criteria for Capitella 291, as we heard, was less than 8. So even with 7.2, it was a very appropriate treatment to choose. Having said that, we can still see the trial showed low-grade hyperglycemia, lower grades grade 3, but in real world, we can definitely see more incidences of that. In fact, that led to, based on the post-marketing data, changes in the package insert to make sure that the monitoring is intensified for capivasertib for those patients who are at risk for hyperglycemia. So I think we have to be vigilant for hyperglycemia management for all our patients and make sure that we dose modify if we are not able to control it with just anti-diabetic medications.
Hope?
She had disease progression on fulvestrant and palbo, so I'll just point out that we have no idea by switching from a CDK4/6 inhibitor to a PI3 kinase inhibitor when you have disease resistant to the SERD is going to result in a long PFS. So the fact that her disease progressed in 3 months may have been contributed to by hyperglycemia, but simply endocrine resistance without the ability to overcome it with the AKT inhibitor.
Well, plus you won't be able to get the CAPI too, but Seth?
Yeah, let me just make 2 comments following up on these great points. First is that we're seeing this really important trend with these newer generation agents. As the therapeutic index improves, we can start to do more triplet regimens, which really wasn't something we could consider a number of years ago. And I think the point that Erica made is really interesting and important one about the PACE trial versus the Victoria 1 trial. And my hypothesis here is that by targeting the PAM pathway, you're taking care of some of the mechanisms that are driving resistance to the CDK4/6 inhibitor. And by inhibiting across PI3K, AKT, mTOR, you're actually getting rid of the factor that was driving the original resistance to palbo, which is why we see more activity by reintroducing the palbo with that agent versus, for example, in the PACE study where you just continue it directly. So I think that's proof of concept that we may be hitting the right resistance target.
So when we assigned Seth to talk about SERD, we didn't know that Ladera was going to be presented. I don't think anybody knew until pretty recently. But before we get to Seth's presentation, just want to ask a very straightforward question to the entire faculty. We're going to start with you, Angie, which is, of course, everybody here in this room has seen this data. What the trial did, randomized giredestrant versus standard of care endocrine therapy. Premenopausal women got ovarian suppression. Although there was some data at ESMO, incidentally, with giredestrant. I think it was a window of opportunity trial showing maybe it could be used without, but it was used with ovarian suppression. Hazard rate of 0.70 for disease-free survival. Survival 0.79, not statistically significant, but kind of encouraging. So my question, we'll start with Angie, is assume you can use giredestrant whatever you want. Don't worry. Don't even get into the issue of approvals, costs, etc. Just pure science. When you go back to your clinic and you see a patient, not only patients who are starting endocrine therapy, adjuvant endocrine therapy, maybe you're already on endocrine therapy, maybe they have an issue. How would you like to use giredestrant?
So I think it was very impressive data that we saw. It's hard to argue with a randomized phase 3 trial of this size. It was interesting that the stage range was actually all the way from stage 1 to stage 3. But it is one trial in a drug that we don't have a lot of experience with quite yet. And we don't have any sense of how it will play with CDK4/6 inhibitors in those higher risk patients. There is a sub-study in which they are looking at it in combination with abemaciclib. So I think that as I think about where I'm going to potentially use this, it may be in the lower risk patients rather than those in which I'm going to be thinking about giving adjuvant CDK4/6 inhibitor. I think that there was some consideration to the toxicity being a little bit easier to tolerate. And I actually like the idea, another group that I might think about are those patients who are really suffering with AI-related toxicity. We have patients who are just torturing themselves to stay on these AIs because they feel that this is something they have to do to save their lives, and they're miserable. So having something that's an alternative that they may tolerate better is another area where I'd like to use it.
So Komal, and I think, Lisa Carey brought up the possibility of maybe giving a CDK for 2 years and switching. There are actually trials with other SERDs looking at that strategy. Maybe we'll land there. What are your thoughts, though, about right now?
Yeah, no, I think very impressive data. Very excited to finally see a newer endocrine therapy option being presented after 25 years of using the same endocrine options for our patients in clinic. That's the very first thing. The second thing, very exciting to finally see some data beyond ESR1 mutations, which is where we kind of relate to oral SERDs currently in the metastatic setting. And why would that be the case? That's because it's an endocrine drug. It should work as an endocrine therapy, and it should work in wild type and mutants similarly in many ways. It's not as simple as that, but at least we can think about that in the metastatic setting. I think it's a lot more heterogeneous, and I think it's very difficult to show the superiority. It was never inferior. It was just that we were never able to show monotherapy superiority in the metastatic setting. So yay for that as well. The third point that was very impressive that Lisa Carey did very well cover was that the early readouts from the ATAC trial, the 2-year IDFS of the Monarchy, the 3-year IDFS of the Natalie, and the early 32-month follow-up lidERA data set all have near identical hazard ratios with near identical absolute benefits of about 2 to 3%. So it's great that despite a high-risk patient population, 70% being node positive, that the hazard ratio with just a single agent endocrine drug, we're seeing similar benefits. It is early days. We want to wait a little bit longer to make sure the way we waited for Monarchy when it first read out, the way we waited for Natalie when it first read out, that this continues to be the benefit. I think it will be, but I think we need to wait for that.
So
the second...
Sorry.
Yeah, no, I was just going to say the second is that you want this hazard ratio to maybe even be better. And maybe with adding a CDK4/6 inhibitor, it might be better. We'll get safety data, as Angie said, but there are randomized trials like Cambria 2, which will also provide that information eventually. And to your point about should we switch, I think we have switch studies. We have 3 of those. Ember 4, we have Cambria 1, we have Elegant, which will address that question and randomize large adjuvant efforts. So I think we're going to have a lot of exciting data. Until then, stage 1, which is not eligible for Natalie or Monarchy, certainly could be an option if this is available. Patients who cannot tolerate CDK4/6 inhibitors at all certainly could be a great option. Patients who don't want to take CDK4/6 inhibitor for whatever reason could be an option as well. I still think we need to wait a little bit more for more randomized data and more follow-up to unanimously use it.
So, Hope, I don't know whether CNN and the New York Times have gotten to you yet, but I'm sure I'm going to be hearing from that soon. What are you going to tell them?
I think this is a tremendously exciting advance. I think that we haven't seen in about 25 years, where we could actually change endocrine therapy and see a benefit. The trial was designed, this follow-up is at less than 3 years. So do we want to change everything we're doing for data that's less than 3 years based on what we have with the CDK4/6 inhibitors and AIs? And I think if you look at the forest plots, what you can see is that the progression-free survival benefit is really driven by the high-risk population versus medium risk using their scoring, and also by the node-positive versus node-negative population. This totally makes sense. It's too early for those patients, and the majority, as was pointed out, did have node-positive disease. So how would we take that, given the fact that those are the patients we want to give a CDK4/6 inhibitor to? We've seen 7-year data with Monarch E with a survival benefit and a near survival benefit with Natalie, as well as a the confidence intervals don't cross 1 now, as we saw for the node-negative high-risk group. So my feeling is that at the present time with the data we have, I'm sticking with CDK4/6 inhibitors. If giredestrant is approved and we can't give it with a CDK4/6 inhibitor because we're going to have just a 100-patient non-randomized safety study eventually, and we don't yet have the Cambria study that allowed only abemaciclib, not ribociclib, the switching studies will take a while since the EMBER-4 trial enrolled 8,000 patients and just finished accrual this week. And then we have Elegant looking at very high-risk populations, so it might be front-loaded in results with elacestrant. So we have all this data coming up. If we had giredestrant approved, I would really try and give it after I finish the CDK4/6 inhibitor in high-risk disease. So not in the node-negative, lower-risk disease, because I think the cost is going to be an issue for patients also.
That's a great point. Erica?
Gosh, I think there's been so many amazing things said about the data so far. So, how can I add to this? Well, first of all, I'd say, in our use of oral SERDs in the metastatic setting, I think we have learned that this category of drugs is extraordinarily well tolerated. And don't we deserve this, and our patients deserve this, to have a really well-tolerated endocrine therapy? So it's really exciting to see this moving forward. I think the data that was presented didn't quite capture this preferred tolerability, and we probably need to see a little bit more from the trial to understand that. For example, a premenopausal woman receiving LHRH agonist is going to have side effects mostly from that. So how can we dissect out what side effects are from ovarian suppression and what is from the baseline endocrine treatment? I also think that, sort of echoing what you've heard, for the high-risk patients, given that data we've seen from Monarchy with an overall survival advantage, I'm sticking with a CDK4/6 inhibitor. For the low-risk patients, I think, we need to think hard about what's going to make sense, for the patient and also for our healthcare system, but it certainly is attractive for low-risk patients. I think what's really interesting are the medium-risk people, like a T2N0, who would be eligible for a CDK4/6 inhibitor for ribociclib and also be eligible for giredestrant. And, are you going to add a second drug that comes with more side effects, or are you going to switch to a different drug that maybe is better tolerated? I think that's going to be very interesting decision-making. But I think in general where we're headed is, oral SERDs are game changers. They're going to sweep away all of our old endocrine therapies, and we're going to have a new class of drugs that's going to be really great. It's just going to take a few more years to get there.
That's a really great point, though, about the fact they were on ovarian suppression. Seth, any other thing you want to add to that? And do you think the day is going to come that we'll be able to give a SERD like giredestrant to a premenopausal woman without ovarian suppression?
Yeah, I've been telling my patients that every 20 to 30 years we're due for new anti-estrogen. This is coming right on time. I don't have too much to add. I do just want to echo a couple of the points that were brought up. Number one, the control arm here, just due to time, is not the current standard of care, and that's what's been alluded to here. And so it's really challenging, for example, on Monday morning to walk into, if this were approved, and look at a patient and say, well, I have the Monarchy with all the follow-up versus this. I do believe, as Erica just mentioned, that the SERDs will sort of wash everything away here and enter a new era in the early stage and later stage setting. There's some very interesting biology here to look at in terms of prevention, for example, of emergence of ESR1. I think that's part of what we're seeing here. But the other thing I would point out, Neil, that was hidden in one of those slides is the hazard ratio on the force plot for tamoxifen versus the AI. We're actually replicating some of the older data inside of that slide. The hazard ratio was much better for tamoxifen than it was for an AI. You can almost see the history over 50 years. Wow. You see the SERD versus tamoxifen had a better hazard ratio than the SERD versus the AI, though it was statistically significant below 1 in both of them. But I thought that was interesting and almost was a historic measurement looking over, from 1977 up till today.
So Seth is my go-to person to explain pathways, and I always depend upon him, and I really appreciate your help with all the surveys we did that we presented here. But let's talk a little bit more about SERDs, Seth.
Well, always a pleasure. This is really intimidating, not only to follow this group, but to be the last talk of your entire San Antonio. So I'm gonna do the best I can here to hold the line. So we're going to talk about oral SERDs and end on this really exciting topic. Let me start by just Again, reviewing the idea of ESR1, Erica nicely went over the fact that PIK3CA mutations tend to be early events. They're truncal. They're present in about 40% of patients, whereas ESR1 alterations, which typically occur in the ligand binding domain of the gene that encodes the estrogen receptor, are very rare in untreated early stage or de novo metastatic breast cancer, typically occurring in less than 5%. This is the importance of repeating molecular testing at the time of progression, where we see increased rates of ESR1 alterations approaching 25 to 40%. And here's an example from a patient who at baseline had the PIK3CA H1047R, and then over time, more than 2 years on endocrine therapy, you can see there are more mutations. There's a higher burden of circulating tumor DNA, and among the new mutations she had is in green the ESR1 alteration D538G. And Erica, again, also nicely went over this data about the relatively high concordance rate between solid and liquid biopsies, though it is not 100%, moving in both directions. And ESR1 has a slightly lower concordance rate and tends to be better detected via liquid assay. And of course, there are advantages and disadvantages to both solid biopsy and liquid biopsy. As of today, right now, the solid biopsy can provide receptor status, ER, PR, HER2, PD-L1. We're not yet able to do that in the blood, though there's some technology coming that I think will allow us to do that. With the liquid biopsy, we have a much better look at heterogeneity, the entire tumor ecosystem across the body. So let's go through a few of these trials: Emerald, EMBER-3, and Avera. Emerald here is the practice-changing first oral SERD elacestrant. This was a prospective phase 3 trial, and one of the things as we commit the cardinal sin of trying to compare across phase 3 clinical trials is to really keep in mind some very important differences between the degree of prior therapy, which differed a lot between these studies. Emerald was by far the most heavily pretreated population. 20 to 25% of these patients had prior chemotherapy. 100% of these patients had prior CDK4/6 inhibitor therapy. Over 40% of these patients had 2 prior lines of endocrine therapy. And you can see here the results. Patients were randomized to endocrine therapy of clinician choice, aromatase inhibitor or fulvestrant, versus the oral SERD elacestrant. You see the ITT on the left and the ESR1 mutant subpopulation on the right. We see those curves beginning to separate further in the ESR1 mutant subpopulation, with an improvement from about 1.9 to 3.8 months. And the shape of these curves is something we've come to expect in this population. We see a steep drop in both arms, a population of patients who seem to be kind of endocrine refractory. But look also at the tail. In the ESR1 mutant subpopulation on elacestrant, we're getting up to 20 to 30% of these patients who have long, durable response on elacestrant monotherapy exceeding 2 years. And then in the middle of the curve, we have some moderate benefit, but these are probably the patients who are better suited for doublet therapy, as we'll think about here. And then in 2024, they went back and looked at some of the subgroups and saw that if you took the patients who had ESR1 mutation, who had longer duration on their frontline endocrine and CDK4/6 inhibitor therapy, we're beginning to see even bigger separations, now from about 1.9 to almost 9 months. And so in practice today, this is what many of us are using to decide which patients we want to deploy this agent as a monotherapy for. And again, I'm not going to belabor this too much. We've talked a lot about it today. These are extremely well-tolerated drugs with very low discontinuation rates. And again, anecdotally, for those of us who've used a lot of these drugs in clinic, they tend to be much better tolerated than aromatase inhibitors, even with a lot less menopausal symptoms and arthralgia. Now, here's some real-world data that our team generated along with Dr. Rugo and colleagues, and Dr. Lloyd, who's our newest attending at Mass General Hospital, is here tonight. We did 2 real-world studies in more than 1,000 patients who had received elacestrant after the approval of this drug in 2023. These are really heavily pretreated populations. So here you can see between the 2 studies, one of them used the Guardant Inform database, the other used the Komodo Foundation Medicine database. 50 to 70% between the 2 studies had prior fulvestrant. These patients, more than 50 to 80+% of these patients had visceral disease, prior chemotherapy. 94+% of the patients in the Komodo database had at least 1 year on first-line endocrine therapy. And we use in the real-world data a metric called time to next treatment, because we don't have prospective radiology to measure progression-free survival. We look at the time the drug started to the time the next drug was utilized in the the database. And here we saw median time to next treatment of 6 to 9 months, slightly higher in the patients with less prior therapy, matching that 2024 subset analysis that we saw from the Emerald trial. There was a trend toward longer time to next treatment with less prior therapy and without prior fulvestrant. There was no impact with visceral metastatic disease. Those patients who had visceral disease were still getting the same amount of benefit in these real-world studies. And here what was very interesting is that concurrent mutations in ESR1 and PIK3CA seem to do a little bit worse numerically, dropping down, for example, into the 5 to 6 month range. And again, this was precisely in line with the 2024 subgroup analysis from Emerald, where there was a decrease in terms of the amount of time on elacestrant for patients who harbored concurrent alterations in PIK3CA. Very importantly, we've begun to learn over recent years that not all ESR1 mutations are created equal. The Y537S can be a little bit more aggressive and tends to do worse on fulvestrant. Here, there was no negative impact. The Y537S patients were doing equally well. And there was a trend toward a higher, worse outcome with a higher degree of polyclonality, having more than 4 ESR1 alterations. Now let's turn to the EMBER-3 study presented by Dr. Jhaveri. This is a really important study as well. Less heavily pretreated population, no prior chemotherapy, only 1 prior line of endocrine therapy, and importantly, 40% of these patients were CDK4/6 inhibitor naive. Again, in the overall population, there was no significant difference with the same pattern and shape of the curves, but in the subgroup with the ESR1 mutation, we saw an improvement from just under 4 months to 5.5 months, as seen here on the right. And this recently led to the approval of imlunestrant as a single agent, again, in the population that have ESR1 mutations. Now, here also we had a third arm with imlunestrant plus abemaciclib. And what was very impressive here in the overall population is that we saw an improvement up to over 9 months for patients who got the doublet. And very importantly, in the subgroup of patients, the 60% who had prior CDK4/6 blockade, that number was almost identical, again, exceeding 9 months. And that compares favorably, for example, to the post-Monarch study where that number was about 6 months, suggesting that by combining abemaciclib with a better anti-estrogen and oral SERD, we may be able to get more mileage even in a post-CDK4/6 inhibitor setting. And again, the toxicities here were very well tolerated, and the drug was easily combined with abemaciclib without a significantly higher rate of some of the toxicities that we've been spending some time talking about tonight, including, for example, GI-related toxicity and diarrhea. And then finally, let's talk about the Avera study, which was also recently presented by Dr. Mayer. And this is a really interesting and important global randomized phase 3 trial. Again, these patients were allowed to have had up to 2 prior lines of endocrine therapy in the advanced setting, no prior chemotherapy. They were randomized to receive standard of care endocrine treatment. You could have chosen an aromatase inhibitor, fulvestrant, tamoxifen with everolimus, or giredestrant with everolimus, as we were just talking a few minutes ago about. And here in the ESR1 mutant population, we saw an improvement from about 5.5 months to 10 months with a nice hazard ratio. And in the ITT, we also saw an improvement, though the curves begin to tighten a little bit. And it's important to recognize that the population had 55+% ESR1 mutation. In this exploratory subset analysis in the ESR1 wild-type group, we see that there really wasn't much of a significant difference, suggesting, again, even in combination with everolimus, not only is the drug combinable, but most of the benefit seems to be limited to the population that harbors the ESR1 alteration, similar to the 2 trials we just looked at for monotherapy. And again, here we've learned that these drugs are very well tolerated. We see expected toxicities, mostly driven by everolimus, that we've all come to expect over many years. And finally, let me end just with a couple of thoughts and future directions. Neil, I feel like I'm changing this slide every 10 or 20 days right now, and I feel like I have to change it even after today. But this is where we were about 72 hours ago. So most people in the first-line setting are getting an aromatase inhibitor with ribociclib. We talked about the triplet for those patients who are endocrine refractory with PIK3CA alterations. In the second line is really where precision medicine is playing a huge role. We talked about options for PI3K pathway altered patients. Now we have 2 approved oral SERDs for monotherapy, and we have PARP inhibitors for BRCA mutant patients. In the third line setting and beyond, if the patient has multiple mutations, we might think about sequencing some of these options in the second line. Or we have ADCs, and we've seen data for trastuzumab deruxtecan in chemotherapy-naive patients showing significant clinical benefit. We have many chemotherapy options. We have sacituzumab and Dato-DXd. But now also we have a lot of this new phase 3 data coming into the mix where we don't yet have FDA approvals. We talked about camizestrant switch for patients who have rising ESR1 alterations. We have phase 3 positive data for vepdegestrant PROTAC in patients who have ESR1 alterations. We have the doublet agents that we just talked about, imlunestrant and abemaciclib, giredestrant and everolimus, and we have the really exciting data from the Victoria study that are going to play an important role in the mix here as we start to see potentially more FDA approvals in the future. We have other really exciting drugs coming online, newer antiestrogens, KAT6 inhibitors, new doublets, new triplets, new CDK4/2 inhibitors, better PI3K, AKT, RAS pathway inhibitors, and new ADCs. So if this wasn't complicated enough, we're going to get a lot more exciting data over the next couple of years. I just wanted to finish by saying we talked about this pattern here, rapid progressors, long-term responders, intermediate responders, trying to use multi-gene signatures and next-generation sequencing to identify which patients fall into each group. And let me just end with the summary. Emerald, elacestrant monotherapy in ESR1 mutant disease. We reviewed the real-world data. We have EMBER-3 leading to imlunestrant monotherapy approval and really impressive results 9 to 10 months with the doublet. We have Avera showing really impressive activity of giredestrant everolimus, mostly in the ESR1 mutant population. We have great safety data. Here are my questions. Is there a role for oral SERD monotherapy, and in which patients? How do we identify them? How will earlier deployment of the SERD impact the landscape if lidERA were to become sort of universally utilized? What doublet and triplet regimens will provoke the most benefit, and when should they be deployed? How do we approach patients without actionable genomic alterations? For example, should we be now deploying GETA in that situation with ESR1 and PIK3CA wild type? What about dynamic changes in ctDNA? How are we going to integrate that into practice? And how are we going to use these ongoing efforts to refine our ability to predict ER dependence and promote better personalization? Thanks.
Thanks, Seth. And I was actually, Komal, flashing back to last year when you presented EMBER-3, and we were doing these CME meetings asking all the faculty, like, what does this mean? Of course, we just went out and started asking people, and in one of our posters here, we asked 20 investigators, would you like to use imlunestrant and abema? And all 20 said yes, some even in the first line. But I want to get back to Hope. In terms of elacestrant, first of all, I wanted to ask you about your presentation here of the Elevate Phase 2 study. We're talking about combinations with SERDs, and Seth was just alluding to which ones maybe we're going to land on. But also practical questions that come up about SERDs and elacestrant and imlunestrant now, Hope, use in visceral disease or patients with aggressive disease, younger patients. A lot of people think about SERDs in older patients. What about the younger patient with visceral disease? A lot of the patients in the trial actually had visceral disease. And any thoughts, anything you want to say about these data that you presented looking at various combinations?
Yeah, we presented the data from 2 phase 2 cohorts from the Elevate trial, elacestrant and everolimus, which was given at a slightly lower dose than standard because it was similar drug exposure and less adverse events, and then standard dose abemaciclib as the second cohort. Half of the group with abema had CDK4/6 inhibitor with either palbo or ribo, and half had not. All of the everolimus patients had a prior CDK4/6 inhibitor, and I think the eligibility are important here because, 30% to 50% of the patients had prior fulvestrant, so this was, a more pretreated population. You could have had primary endocrine resistance, which was a subset of patients on 1 to 2 lines of prior endocrine therapy, and what was interesting was in the actual data, we had, 70 to 90% of the patients having visceral disease, which I think is kind of surprising for us. We're in median 1 line of prior endocrine therapy in this population. And then the median progression-free survival with elacestrant and everolimus was 8.3 months, regardless of whether you had an ESR1 mutation, a PIK3CA mutation, or had visceral disease and other factors. So that was, I think, really impressive. And with elacestrant and abema, keeping in mind half CDK4/6 inhibitor, pretreated, half not, was 14.3 months. And again, we saw the same number in patients who had visceral mets. We don't have the mutation data yet, or prior CDK4/6 inhibitor, but we'll have it next year. It just doesn't have enough median follow-up. And the safety signals were great, as was previously discussed. We really didn't see anything different than what we would see with standard endocrine therapy combined with these targeted agents. So that was very encouraging. And of course, 7.5 of everolimus, you have less toxicity. So that was a good thing. So I think this is really encouraging data, fits well with what we've seen otherwise. I think it's really exciting to now have some combination options that may be effective outside of having the ESR1 mutation. We've really been waiting for this.
So, Angie, 103-year-old woman with locally advanced disease. The story is she presented at age 98 with a locally advanced breast cancer in 2020. I don't know if you remember 2020, it was a pandemic. And so everybody was all panicked. Nobody wanted to come to the doctor, so he just gave her letrozole, said to come back, but she didn't come back. So for 3 years, she sat at home, or I think 2.5 years sat at home, then came to Dr. Astrow with even worse disease. And at that point, I think she was 100. Here's what happened.
When I first met her, she was 100.
Wow.
And she has a really very far locally advanced breast cancer because she hadn't left her home since the beginning of COVID. It just looked horrible when I first saw her. And, you could wonder, she's 100 years old, so you could argue, what are we doing? But, she's happy to be alive. So, and she wants to live. She lives in her own apartment independently. When I first saw her, I sent her for some palliative radiation. I sent a Guardant, and I found out she had an ESR1 mutation. So I started her on elacestrant. So one of the questions is, if you have an ESR1 and they haven't had a CDK4/6, what's the preference here from the faculty panel? Is there any new data combining elacestrant with a CDK4/6 inhibitor?
Currently, is she still bleeding and having
pain?
No symptoms?
No bleeding, no pain. It's still quite visible, and she's still troubled by. She says to me she'd like to be able to wear a low-cut dress again. That's what she says to me.
Wow. Any other questions about this case?
Would you consider any chemotherapy for this patient? Weekly Taxol, TDXD, sacituzumab? Just wondering what the faculty panel's experience is treating people with some of our newer agents when they're at an advanced age.
So Dr. Astrow's in the Bronx. He actually presented a 91-year-old who got TDXD and did well, responded, very little toxicity. So interesting. And also interesting about this case, Angie, she had an ESR1 mutation but had not been on a CDK. This is just from letrozole. I thought it didn't happen, but then I think I saw 5% in Lisa's talk or something. Anyhow, any thoughts about this? Would you have given her a combination at that point?
First of all, I thought the use of palliative radiation was a great idea. The key here is to do no harm. And in general, I think about physiologic age over chronologic age. However, I think once you hit 100, all bets are off. I like the idea of the elacestrant. I don't know that I would feel compelled to add the CDK4/6 inhibitor immediately. I'd like to take a stepwise approach and see how she does.
Great thoughts. So I want to thank the faculty. Thank you for coming all 3 nights. Have a great evening. Thank you so much.